Hello, PsyQ community, and welcome to today's presentation, Managing Metabolic Side Effects with Combination Therapy, Antipsychotics, and Antidepressants. My name is Brian Dickinson, a consultant for Open Minds, and I'm here with Dr. Michael Thase. Dr. Thase is a professor of psychiatry at the Perelman School of Medicine at the University of Pennsylvania. He is also the director of the Mood and Anxiety Disorders section and is a member of the medical staff of the Corporal Michael J. Crescenz Veterans Affairs Medical Center. Dr. Thase received his medical degree from the Ohio State University College of Medicine in Columbus, Ohio.
Thanks for that kind introduction. I just want to remind everyone that this program is paid for by Otsuka Pharmaceutical Development and Commercialization Incorporated, as well as Lundbeck, LLC. And as a speaker today, it should be recognized that I am a paid consultant to Otsuka Pharmaceutical Development and Commercialization. We have three objectives for today's talk. The first is to review the mechanisms of action and rationales for using antipsychotics, antidepressants, and their combination. The second is to highlight common metabolic side effects associated with these therapies. And the third is to discuss the optimal management of metabolic side effects. So let's just begin at the beginning and talk about the mechanisms of action of these two classes of medication and how they can have compound effects. Of course, we know that most antidepressants work by modulating norepinephrine and serotonin. Primarily, most of the common antidepressants we prescribe actually block the reuptake of these two classic monoamine neurotransmitters. The antipsychotics have a more varied range of effects, and there are differences between the initial or first generation and the so-called second and possibly third generation of antipsychotic medications. I think importantly that some of the newer antipsychotics have biphasic effects on dopamine neurotransmission so that they can actually have partial agonist effects at lower doses and then become antagonists at higher doses. I think critically some of their secondary effects, including blockade of the serotonin 2 transporter and antihistamine effects, can explain why some of these medications have metabolic side effects, including weight gain. There were decades of study leading to the first consensus statements about the role of these newer generation antipsychotic medications in the care of depressed patients. And I think both the ECNP consensus meeting and then subsequently the revised third edition of the American Psychiatric Association practice guidelines pointed out that these medications had antidepressant enhancing effects, so they could be used as an adjunct to an antidepressant medication, and that these effects were not tied to the antipsychotic effects of these medications. So they weren't just limited to patients who had a psychotic form of major depression. So if we think about polypharmacy, or the use of two medications of different classes for patients, we've been doing some of this for a long time. And if you think about the antipsychotics, there's even on occasion an indication for patients with treatment refractory schizophrenia to use two different antipsychotic medications at the same time when monotherapies haven't had the desired effect. Similarly, in bipolar disorder, the use of newer generation antipsychotics in combination with mood stabilizers has become one of the standard acute phase and sometimes maintenance phase or preventive phase interventions. And of course, certain newer generation antipsychotics are also indicated as therapies for episodes of bipolar depression. And then, although more controversial, there is a literature that suggests for patients with obsessive compulsive disorder, or OCD, that antidepressant medications can be benefited by the addition of a newer generation antipsychotic medication. And again, these particular benefits in OCD, bipolar depression, and major depressive disorder are not limited to patients with psychotic features in an episode of illness. So the use became widespread, and I think by 2015 or thereabouts, the adjunct use of the newer generation antipsychotic medication has become kind of the number one type of medication added to an antidepressant to try to enhance the effect. And so these benefits are typically observed within the first days or first few weeks of therapy, so you can see benefit coming, but along with the benefit comes the obligation to minimize side effects and ensure safety. And so this brings us to an area then that our colleagues in schizophrenia have had to be mindful about for more than the past 15 years, and that's namely the potential consequences of metabolic side effects and metabolic burden associated with longer-term adjunctive therapy with newer generation antipsychotics. So let's start at the top. People with serious and persistent mental illness are at greater risk for cardiovascular disease and cardiovascular mortality. So there is something about these illnesses, and here we can include severe recurrent major depressive disorder, treatment-resistant depression, and bipolar depression are associated with a greater likelihood of having heart disease and a greater morbidity and mortality associated with heart disease. And now you can see then developing in the 21st century newer risk factors reflecting earlier and longer onset of depression in younger people that include the development of obesity, which is both a predictive or a risk factor for depression as well as a potential consequence of longer-term chronic depression. And then associated with the general risk of obesity is an increasing risk over time of type 2 diabetes. So these particular risks, which are innate or inherent to the illnesses themselves, can then be exaggerated or amplified by medications that have similar side effect profiles. And so this is particularly true, of course, for the risk for overweight or obesity during treatment with the newer generation antipsychotic medications. And of course, this was a risk factor for some of the first generation of antipsychotic medications also, but because of our fear or concern of tardive dyskinesia, we did not use them nearly as commonly or with as much confidence for treating patients with difficult to treat mood disorders. Now, I think there's a wide range of metabolic risk and metabolic burden from medications in which 50% or more of people can develop a metabolic side effect during a several-month course of treatment, down to a more uncommon kind of incidence, like 5 or 10%. But none of the antipsychotic medications, I would say, is truly free or inert when it comes to metabolic risk. The risk goes from a small risk to a large risk, and that's the gradation we're taking into account when we select a particular medication. So why don't we start at the top? The number one metabolic side effect associated with longer-term treatment with antipsychotic medications is weight gain. And any weight gain is an unwelcome side effect, except for the patient who has lost a lot of weight in the course of antidepressant, in the course of the episode of depressive illness. But even then, we got to track weight gain as a potential side effect, because the earlier amount of weight gain, even when it might be restorative in somebody who's lost weight, is a predictive factor for subsequently developing problematic weight gain. Now, for many years, the FDA has used a 7% criterion as just an arbitrary or absolute definition of problematic weight gain. And there are some issues with this one, because say you take somebody who weighs 100 kilo, and so that's 220 pounds, right? So for that person, a 7% weight gain actually represents 15 pounds. So that's a lot of weight gain. And that's a lot of weight gain typically measured across 4, 6, or 8 weeks. And that is indeed a real risk factor for subsequent development of obesity and the cascade of metabolic side effects that go along with it. So again, you can't gauge how much weight gain there is unless you know the person's weight at the beginning, unless you're engaging the person in a kind of reasonably accurate process of monitoring, recording weight, and that you've got a baseline and you're looking for change against the baseline. I do like to tell my patients that no one gains 10 pounds or 5 kilo, which I know technically is 11 pounds, but no one gains this amount of weight without first gaining half that amount. And typically no one can gain half that amount in 1 week's time. And so you do generally see it coming if it's going to develop. Now, of course, edema can cause weight gain. That's a different presentation, but when we're talking here about the development of adiposity, and that you generally see happening on a pound a week or a pound every other week kind of basis. So you can see it coming. So how does this happen? Well, I mentioned that some of our medications have serotonin 2 blocking effects, and some have antihistaminic effects, and some have both. And those medications can stimulate appetite. And for some of us, perhaps individual differences, that appetite stimulation could take the form of calorically rich, tasty foods, so sweets, things high in butterfat content. And so sometimes patients will tell you that they're gaining weight without an increased appetite, that they're not actually taking more in. Maybe simply their taste preferences have shaped them away from foods that have less caloric burden to foods that are tastier and sweeter, and they don't just notice the difference. So one mechanism, plain and simple, is increased caloric intake. Now, it is also possible that if the patient had agitation or increased motor activity as a symptom of their episode of severe illness, that a slowing in this kind of activity can promote weight gain. And so it's possible that the person, as part of recovering, experiences weight gain. It may also be that the person is sort of dampened down and is actually less active than is their nature when well. And so that person, say you move 1,000 steps less a day, you might not notice the difference, but if you tally that over, say, the course of a month, that's 30,000 steps. There are somewhere between 1,500 and 20 and 2,000 steps in a mile, and so you can work the caloric burden of this decrease in activity. Now, it's also possible that there are modest modifications in metabolism, and this is less well understood, but even when you've got a handle on activity and intake, which you often don't without proper monitoring, it may be that there's still other factors that can be associated with weight gain. Now, I do want to say that the weight gain observed in 6-8 week studies of adjunctive treatment tends to be greater than the weight gain observed in similar sized studies of schizophrenia, even though the doses of the antipsychotic medications may be greater. Now, this could suggest additive potential between antidepressants and antipsychotics, and it might also reflect differences in illness pathophysiology. Let's turn our attention now to a more ominous, not as common, fortunately, but a more ominous metabolic side effect, and that is the risk of diabetes. And diabetes, again, is associated with an increased risk of depression. And people with depression have an increased risk of diabetes, so it's bidirectional. And along with weight gain, there is a heightened risk of type 2 diabetes. This can, it's a polygenetic or multifactorial process, but being overweight is one of the most common factors. And there are also modest associations between using antidepressants and in the long term, a risk for diabetes. When we watch closely, generally the risk is associated with weight gain. Generally, there is not an increased risk in the first 4 to 6 weeks in measures of insulin metabolism, although for some of our antipsychotic medications, you can see changes in blood glucose, changes in insulin level within the first few months of therapy. And these are not always directly linked to weight gain. And in particular, the most kind of fulminant and ominous of the diabetic complications associated with antipsychotic therapy is the sudden onset of severe diabetes with metabolic acidosis or ketosis. And this can happen without any weight gain whatsoever. Now, more commonly, but less ominous in the short run, is dyslipidemia. And here you have changes, again, that are largely driven by weight gain, but not entirely driven by weight gain. And so what can happen is that there can be an increase in triglyceride. This often passively follows increased weight and not paying proper attention to diet, but you can see changes in the balance of high density and lower density cholesterols as well, so that the ratio of good cholesterol to bad cholesterol decreases, reflecting a worrisome metabolic shift. So antidepressants per se are generally not associated with dyslipidemia, but you can see this invoked simply by weight gain, and this in turn is exaggerated in patients taking newer generation antipsychotics, predominantly in association with weight gain, but sometimes developing de novo. So if you're going to do longer term therapy with a newer generation antipsychotic, it's good not to have only a baseline battery, a baseline weight, and be monitoring. But if it looks like the treatment's been very helpful and that you're going to be with it for some time, you should get a baseline or near baseline cholesterol battery as well. I think lastly, there is the metabolic side effect of hypertension. And of course, SNRIs, the antidepressants that affect norepinephrine as well as serotonin, have a small but real risk of increasing blood pressure. And for some people, during longer term therapy, they can develop hypertension as a consequence of SNRI therapy. This has been reported for bupropion, whether used alone or in combination with SSRIs also. Depression in and of itself is not generally associated with high blood pressure, but it can be associated with receiving poorer care for your high blood pressure, because people with depression are less adherent generally to their therapies. So I think the main thing you want to watch out for is the development of high blood pressure over time in someone who has consequences of a significant metabolic burden. So let's come back, and again, we really are talking about risk and benefit assessment. And so I think, first of all, unless you can fully appreciate the possible risk, you cannot make an appraisal about the benefit versus risk assessment. So let's begin at the top. In studies, controlled studies with a placebo control using an adjunctive therapy design, the likelihood that someone will show a large and clinically meaningful improvement on a newer generation antipsychotic added to an antidepressant, there's a benefit that you can expect, let's say on average about 15% of the time, over and above the placebo effect. In controlled studies, the number generally ranges between 10% and 20% over and above the placebo effect. So that's the benefit. Now, against that risk, you've got to put in the risk of weight gain, which across 6 or 8 weeks is going to be some number between 1 or 2% to 7 or 8% over and above the effect of placebo. And then during those first 6 to 8 weeks, you're not seeing much risk of changes in lipids or changes in blood pressure or changes in insulin or glucose metabolism. So again, early in treatment, you're carefully monitoring weight gain as the harbinger of risk. So you must also then take into account other considerations. So for example, does the person have a history of cardiovascular risk factors? What is their, not just their weight, but their BMI, to get an appraisal of if they have too much adiposity? You can generally index this in a meaningful way, looking at the circumference to the waist versus hips. And here, numbers over 1 are worrisome, and sometimes you see numbers as high as 1.5. And the more central adiposity, the greater the risk of subsequent metabolic burden. Yeah. And if you're going into long-term treatment, with the medicine's been effective, you're likely to continue it. Having a fasting blood glucose and a lipid profile becomes as important as having serial weight monitoring. So now we've established that you can measure the risk, you can monitor it, and you can do an appraisal of what you get in return for the potential benefit. So how are we going to manage it if it's starting to happen? Well, forewarned is forearmed. and so the pace of weight gain in the early weeks of therapy is one of the best indicators whether there's trouble ahead. And so you can calculate the amount of caloric sacrifice, if you want to use that term, that it takes to offset weight gain, simply by knowing that a pound a week of adiposity translates into about 500 calories a day of caloric reduction. And so it's hard for people to give up 500 calories a day of caloric intake, but that's what it takes if you're gaining a pound a week during treatment with one of these medications. So getting a dietary consult, getting an appraisal of how the person's taking in calories, reducing the volume of high-calorie, sweet-tasting drinks or beverages, beer, other alcohols are very calorically rich, and of course sweets and desserts and so forth need to go. Again, 500 calories a day translates into a pound a week. If you can reduce 500 calories a day of intake through things that aren't essential, maybe you could get on top of it. How about increased activity? Well, increased activity is a less efficient way of losing weight than reducing calories. The effort it takes not to eat 200 calories or 300 calories of something sweet takes a lot more effort to burn off through vigorous exercise. But some exercise is part of well-being, and so trying to get folks moving more, using some activity goal, keeping track of it, charting it. These are reasonable strategies that can help people make a difference. Now, if you're not making headway, you've run out of real good options for switching medications, because switching from the medicine that's causing weight gain to a different medicine that maybe has a lower potential for causing weight gain is an option. Then you want to think about possibly metabolic interventions. Very often my patients are under the shared care of a primary care physician or an internist who's much better at making these decisions or not. And so a good consultation and collaborative care, working with the patient's primary care provider can help here. Occasionally, if you check the thyroid, you'll see that the TSH level has crept up, and optimizing thyroid to the top of the normal distribution can also be helpful. And of course, along the way, you don't simply have to change antipsychotic medications. You can stop and see if the patient requires one for benefit. You might even consider a lower dose along the way. I think that finally, in addition to having a consultation for a dietitian to help the person with caloric management, there is some benefit for some people by actually participating in exercise groups. And there is a form of cognitive behavior therapy that's tailored to facilitate weight loss, as an example, and encouragement. And it's human nature to benefit from social support. Weight loss can be a lonely and hard thing to do. Sometimes you've got little support of this in your natural world, and joining a group, maybe even a group that is supported and facilitated by the mental health facility that you work with, can be helpful adjunct. So just to kind of sum up in terms of what we're looking at, I think it is important to have a weight chart. It is important to have a baseline set of metabolics if it looks like long-term treatment is in order. And I think not just for minimizing metabolic burden, but because of the small but real long-term risk of tardive dyskinesia, it's best to consider these adjunctive treatments to be time limited if possible. And if the patient's had a good result over several months with some evidence of metabolic burden, then thinking about reducing the dose and possibly discontinuing to establish that there is benefit is a way to go. So the notion that I'm trying to underscore in today's talk is not that the risk of newer generation antipsychotics is too great to subject patients to the possible benefits. Just the opposite. The benefits are clearly established and well calibrated, and typically can be estimated, can be achieved in the first weeks of therapy. So you have good evidence whether the treatment's working well enough to justify the potential risk. And through early weight gain, you have a good indicator of who's at greatest risk. And then for those who seem to require longer term therapy, you have standard, well-established methods to monitor the risk, and then pathways, ways of getting help when the risks seem to be becoming, unfortunately, realities. So I'd like to just simply sum up by thanking you for joining today. I hope this information is helpful and useful, and look forward to the chance of talking with you on another occasion.